was really interesting and it was very thought-provoking, and we wanted people to have time over lunch to have that networking opportunity and also think about questions. So I've got some written down. If there's anything that's occurred to you over lunch, then we've got a roving mic. You'll have to give Joe, who's in the middle of the room with the mic, the chance to get to you. So at short notice, Nick Markwick, one of our patient representatives, has kindly agreed to come and sit on our panel, because I think that one of the perspectives we don't always get is that of the patient. So I think Nick's actually got a question of his own, and because I'm in the chair, I'm allowing him to ask that. So we'll kick off with the first question, which is from Sussex Community, from somebody called Vinny. I don't know if you want to identify. Vinny. You reported an improvement in assessments. Do you attribute this to the tool or the process of implementation, which probably created more awareness? So I think that's for you, Ellie.
I think that's for me. Thank you. Thanks for the question. And in fact, Suzanne and I were just discussing, I think we put the improvement down to the whole framework. So you can't attribute the improvement just to the tool itself, but to the whole framework. So you can use the tool, but if you don't then act on the tool, you won't reduce pressure damage. So I think it's really important that if you're using the tool to improve practice, what you're thinking about is what's the framework you're operating in. So what are you going to do with that in terms of improvements? You know, have you got a strategy that acts on the tool? So I hope that answered your question. Is that all right?
The next question is from Maggie Davis, who's from Western Sussex Hospitals. There's Maggie. What is the research data to support Purpose T in terms of improvements of patients' care? What difference has it made to patients? This is actually more than one question, Maggie. I'm going to have to call order on that. Was there a reduction of 3s and 4s? Was there an increase of reporting? So again, sorry, yes.
Shall I start? I'll let you do the evidence base, but I'll definitely start on. So in terms of the improvement, we did see a reduction in 3s and 4s, but also in 2s. So as Joe said, our SI numbers dropped off to the point where CCGs were ringing us and saying, you don't seem to have any, what are you doing? And I assured them they weren't under the carpet. We had actually stopped having 3s and 4s, and most of that was because we were hitting earlier in the pathway by better identification. And one of the things that staff come back and say with Purpose T is it's so simple. So with Waterloo or Braden, there is a lot of judgment in there, and often complexity and subjectivity. And with the Purpose T, it is much clearer. It either is or it isn't. You're either at risk or you're not, and so it's so much easier to implement. So I think the improvement came, for me, from staff recognising it and then acting on it because the tool was simple. But you can't take away that we did a big education drive and that we did put that in a bigger framework in terms of pressure damage prevention being everybody's business. It's very hard to pinpoint it on the tool itself, but I would suggest that the tool was an enabler for change for us just because of the simplicity. And as Suzanne was saying, it's quite hard to get it wrong. You've had a go at it yourself today. You don't need to be an expert in skin integrity and pressure damage prevention in order to work out whether a patient's at risk, and that enables better identification. Did you want to just talk about the evidence base?
Yeah.
In
terms of improvements to patient care. Yeah. Well, I think we're in the early stages. We're obviously implementing the tool from the perspective that the development has been robust and is very evidence-based. We've got the systematic review, the consensus study, the involvement of patients and carers. In the future, obviously my work is primarily around research, so we're going to be looking at research in the future about what interventions work to help improve patient outcomes, and part of that may well include Purpose T.
Sorry, Maggie, to pick up your last point around does it improve patient care, I think undoubtedly yes, and I think that's come from particularly the drop in 3s and 4s, but notably our drop in category 2 pressure damage. So I really think that has made a big difference to patients in our care. So they're not even starting on that journey now. So we're hitting them so much earlier in the pathway. And they're also involved with that project really in terms of their own care.
I'd just like to make one point what Ellie said about the serious incident process and the reduction for SCT and why they had to sort of run the gauntlet with the quality teams, really. For those of you that aren't aware, the new serious incident framework that was released on the 1st of April this year, and STICE has suddenly today come in line with that for all of us that put data on. NHS England took a slightly more pragmatic approach with pressure damage and have categorised category 3 and 4 pressure damage, instead of having just that as a title for SI, have said that meet SI criteria. Now, unfortunately, that is still in discussion with what that means, but really it's down to severe harm. And I think it's up to the quality teams within commissioning to link very, very closely with their providers, because SCT have been able to demonstrate quite strongly an assurance network to the quality teams that they are robustly managing the system in-house before serious incident is actually logged. And I think that learning in particular needs to be cascaded so that the assurance process is followed that robustly. But they did have to run a gauntlet of what seemed perhaps a bit like micromanaging at first, but they're there now, and I think that is a message that perhaps needs to go out generally.
It was really just to reinforce that it is not just about one. It's not about an instrument. It's about the, the whole package. That and the leadership that goes into that, and the framework really that it hangs in. But it can help, is what I'd say.
Can I just say, from a patient perspective, just looking at the assessment form, which is very simple, very intuitive, and the colours, it's quite a good, patient education tool almost, to give them, ideas of what to look for, what to watch out for.
Nick, did you want to ask your question now?
Okay, I wanted to know when in the sort of the patient pathway you'd actually carry out the assessment, especially say for somebody, for instance, like me. I perhaps end up in hospital, in A&E. I'm not particularly able to tell you what's going on. When would you actually assess me for, if I ended up laying on a trolley for 4 or 6 hours, that would be it for the next 4 or 6 months. I'd be trying to heal a pressure sore.
So, I'm from a non-NHS perspective, normally the assessment should be done when a patient, as near to the patient arriving as possible. So for yourself with...
Have we got anybody who's in an ED or an A&E in the audience? Or does anybody want to tackle that question from Nick?
Thank you. I guess to some extent that there is some indication simply by looking at a patient immediately, I've identified somebody at risk.
But that relies on you being...
Of course it does. Of course it does. But I guess that risk assessment, is there an indication with that risk assessment who needs to be completing it? I guess in the same way as we've done with Waterloo.
So I think I've just looked at our last 2 grade 3 and 4 pressure areas, and exactly that situation has come up. We've got to move away from thinking about pressure damage happens on wards to it happens either in the journey in, what's happened at home, but also in the ED department and when we're under extreme pressure and patients are there for a long time. So I think it's about starting that front of door process, skilling up our A&E staff, so absolutely while preventing it. And sounds very simple, but that's a huge change from treating people and getting them home to actually there are people who are essentially becoming inpatients during that episode of care. So I think that's where the Purpose T would have amazing impact if we could be using that assessment tool with the care bundle at the front of door for all our patients.
You see, for me, I'm fairly well educated with I broke my neck when I was 22. It's a long time now since I've done that. And the first thing I asked for is a pressure relief mattress. And I tell the staff I actually need something to be done. Yeah. But if you don't know that, then
from my perspective, I'm a community trust, but we have 8 inpatient units. From my perspective, it's the minute somebody arrives, is referred into our service. So in a similar way that Maggie's just talked about, hitting the front door, for us, as soon as somebody's referred in, the requirement is to do an assessment and to complete the Purpose T, because we need to know the minute we see you, whether or not you're at risk or not. And if we are not able to have a discussion with you around that, or someone who has come with you who knows you well, then we would make a professional judgment. But that doesn't mean we wouldn't revisit it. So I think one of the things that Suzanne and I were talking about, it's really important that you don't just do it once and archive it. It's a tool to use to inform your professional judgment. It's not an outcome in itself.
I'm just going to, our framework, sorry.
Just picking up the framework we use, Ellie, because our operational framework, which Ellie's sort of mentioned, which is part of the sort of strategy, if you like, driving how we do our assessments, specifies the timeframes we expect clinicians to do that in, and that's what we audit against. So again, that's another way we're trying to make sure people are done quickly.
There's a hand at the back there, Joe. And then that lady with the lovely flower in her hair.
Can I just extend what you're saying to disabled people who come into outpatients? Because it always seems to be something that's missing. And certainly if you work in the community with patients who, you know, have been living with a pressure ulcer and hopefully an improving pressure ulcer, there aren't really the resources at the moment, the way that outpatient departments are set up, for those patients, A, to be hoisted appropriately so you can actually carry out proper investigation, or B, that they might be sitting about outpatients in the same way that they do A&E. And I never hear the focus on that. But, you know, as community nurses, when your patient comes back from what is a fairly routine appointment, but they've sat in a wheelchair for 6 or 8 hours, it's quite devastating, the impact that has either on a current or in a pressure ulcer that might just develop from that, even with forward planning about it. You know, the resources just aren't there for them to be on a bed for some of that time, to be on a mattress. Yeah. They're sitting in their own wheelchairs, possibly without even an appropriate cushion that was designed for that kind of use.
Can I just add to that? I mean, I'm the patient rep for patient transport for Surrey. And looking at the figures, the amount of time some people are waiting from, you know, to go home after an appointment, 5-6 hours sometimes. Yeah. It's not good enough, really.
I'll just pick those points up. I don't have a large outpatient contingent in my trust per se, but I think your point is really, really valid. And one of the things that we did when we did our data analysis is we really clearly picked up patients who were under our care, who we'd put in all prevention measures, who were attending outpatients or dialysis or other treatment, you know, chemotherapy treatments, where they were away all day and coming back, and then we were going in the next morning. And that is something that when you analyse your data is really, really important. And so we're meeting up as a cross-collaborative in various areas with our acute partners, and we're trying to engage the ambulance trust, because actually the prevention measures we put in should travel with the patient. So prevention should be going into the ambulance and getting to an outpatient setting. So I think we have got some work to do, but we have identified that as an issue. And, you know, you're absolutely right, Nick, it's not acceptable. Apart from that, it's exceptionally uncomfortable. It's also about we're not supporting people to prevent harm.
Okay. I've got a question from Helen Martin at Medway Community. We'd welcome any tips or ideas about how to manage transfer of care concerns as patients move between services. So,
I'll give that one a go. I feel like I'm monopolising here. Yeah, so what we've done some piece of work on developing a transfer form, which I noticed that Sally was talking about this morning. And we, as part of the collaborative, what we're saying is, as a community trust, this is the information we need, and the acute trust saying this is the information we need. One of the things that we're trying to develop across the economy is a pressure damage passport, in a similar way that we use a catheter passport that belongs to the patient, and they can take that with them to say, these are the measures, these are the preventive measures I normally have, this is what I need to support me in my prevention. But also, if there's treatment is following best practice, then we need to be following that through wherever they're being seen. We haven't solved it, but we've started the dialogue, and by bringing acute nurses together with community nurses, and it's really interesting to see how it's very difficult for each professional to understand what the other professional understands about your role. So a lot of it's about unpicking, well, this is why I need that, because when you come out in the community, trying to get something at 7 o'clock in the evening is a real challenge for us. So if you let us know early enough, we can get it. So it's all about developing that understanding and then smoothing the pathway through. But I think transfer is one of the key things for us. And I think in that we need to include the ambulance service.
Can I just add to that? Yeah. I mean, you've got things for people who have learning disabilities and dementia.
Yeah.
They've got sort of, this is me. Yeah. You don't want to get too many different bits of paper, and it all gets a bit confusing.
Yeah.
But I think it's an excellent idea. It's just trying to have a holistic approach.
And I think that's a really good point. I think what we'd like to move to, obviously, would be your own record. But because we're not there yet, most of us are quite away from having your own patient hold record. It's about trying to make sure the information goes around. But we would be talking to our patient group, Nick, around what do you need to go in with you? What do you find really, when you transfer from community care to acute care, what is it that's so difficult to get across around your care? And what is it that you want us to do when you come back out? Because it isn't actually about us, it is about patients.
And I think some of these, as I'm listening to the answer to some of these questions, I'm really minded. I was talking to Anita in the break about the fact that I don't know how many years pressure damage experience are in this room collectively, but there's got to be an awful lot. And so in terms of answering some of these questions, what I think I'm going to do, and I'm looking at Mike, who's the comms guy, who's going to help me do it, but he doesn't know it yet, is put the questions on the website so that we could have some traffic about, so if any of you have got anything like that idea, or you've cracked it some other way, you can stick that up, and it will be a forerunner of something the collaborative wants to do, which is create some kind of portal where you can park your best practice. And I've been around a while and we haven't cracked that yet, and it never fails to amaze me how much great work there is and how little we all know about what each other's doing. So that's kind of triggered some improvement work for me as well. The next question's from Pauline Robinson. Oh, yeah. Incidents before and after implementation. It's very concise.
So we... Thanks, Pauline. It's really interesting. So incidents before and after. So we saw a 14% drop in the number of incidents of new pressure damage acquired in our care since implementation. But as I said before, the caveat to that is it's not just about the tool, it's about the framework. But what's very interesting around when you report a 14% drop in incidents, it's the impact on the prevalence that was really noticeable. So not only have we not reported an incident occurring, then we haven't got ongoing pressure damage in our trust, and that's very good for patient care. Is that what you were looking for? Oh, okay.
Okay, so that's the end of all the questions that people put forward. Has anybody kind of had a burning question come to them as we've been sitting, or they had over lunch? Sorry.
Thank you. Have you considered, or is it possible to split the tool into two parts? So if, for example, the screening bit, could that be used by carers who then refer on to community nursing to then do the comprehensive assessment part of it?
Sorry, that's a failure in my plan.
We haven't thought about that, but what we have done is gone through the tool with carers. And the reason really we haven't gone that far is because we need to be secure in our own implementation of it before we took the next step and really understand, were our support workers and were our domiciliary carers able to take that on with confidence and to flag up in a timely manner, because I think that's the key, particularly for a community trust, is once you notice they're at risk, we need to be doing something about it very quickly, rather than just it's at risk and then it goes back and it all gets in a lovely process but takes ages. So we haven't looked towards that at the moment. However, what we have done is enabled all of our workers to implement the first part of the tool until they get to a point where they need specialist knowledge around pressure damage categorisation. Did you want to?
Yeah. I guess the tool was obviously implemented to have the 3 parts that it's got, but having said that, I am aware of another place that in a prison population actually are using the screening element of it, and then which is used by other kinds of workers. Obviously we tested it with nurses, but we've got to kind of moving forward, recognise that we've got a kind of change in workforce, and we need to kind of feel our way, I guess, really, and see what works and what doesn't work.
It's a good idea for domiciliary. Are you thinking domiciliary care as? Yeah, because one of the things that we've been trying to sort of reach into is that domiciliary care element where we're providing professional advice, but we're reliant on domiciliary care sort of carrying out that care package. So we do a lot around giving domiciliary carers what we call a care plan that they should be following. But you're right, if we enable them to recognise risk earlier, it might help us with, because we talk about red flags in that, but actually perhaps what we need to do is give them a tool. So yeah, I'm quite prepared to think about that.
You wouldn't want a delay. Too much delay
That's the thing.
If you need to do a full assessment.
Yeah.
So you've got to kind of think things through.
Yeah, it is acting on it, isn't it? That's the key.
It fits in with what we've been trying to do about raising awareness and who to contact. So rather than getting bogged down doing lots of assessment and involved, we'd rather just pick the phone up. But if there was something that helped
them decide,
through and trigger it, then that we'd be willing to trial that.
I think that's a great point. Yes.
I mean, being a receiver of domiciliary care and having a large, I mean, I don't choose to employ my own staff. I've got a care agency providing, and you get a big, you've got a fairly constant group of carers, but sometimes you get odd ones coming in, and sometimes you get different ones who don't need twice at night, and getting you in the right position. So there's you've got this huge cohort of people you're trying to educate.
Yes. I think
but it is important. I agree. You should. I think if you don't if you don't bring them into the circle, then you're missing a big trick.
I think one of the collaboratives that we're involved in around Brighton and Hove, we're trying to look at competency framework. This is health looking at it towards domiciliary care, but looking at a competency framework for domiciliary workers, which would also work in residential care settings. And one of the things is, what are the critical things we need them to know about skin and prevention? It is about getting early. It's less worrying about what you do. It's more about doing the prevention for me. So I think it would fit in with that.
And I also think, because my job before this was around patient and public involvement, and I think that sometimes we expect patients to be passive recipients of everything we give them and information, and actually anything that allows them to. Not everyone will want to take control or take a part in doing it, but actually, if there's a tool that encourages them to do that makes them feel part of engaging in that prevention piece, I think that can only be healthy, really. There's another question. I'm going to send this. I learnt my lesson from the last mic situation.
Hi, I'm from a more acute setting rather than the sort of outdoors, and I just wondered whether you saw this. I mean, obviously it's great. We really like it, and we were just wondering whether you could do it daily. We currently do ours daily, you see, and come up with a score each day, and and all that sort of thing. But we have it within our skin bundle, and then we have it, tied in with the must score, and it's all everything's all tied in together. So implementation I think would be tricky, but would it? How could you see it? Us using it.
Which environment do you work in?
Well, we work in intensive care.
Right.
But the skin bundle is used throughout the hospital, so it's just an acute hospital as opposed to a community hospital. So
I think the perspective really is where there's a change in the condition, and I think what we've been trying to say is that just reassessing and not implementing is not going to work. So from my perspective, which is not from an NHS thing, it's about recognising changes in conditions. Because we know that in practice, often it's not work, the risk assessment thing. It's the linkage between the risk assessment and what you do about it that's important. So that's from my perspective anyway.
I think from my perspective, and I hear what you're saying about your group of patients, I think from my perspective, I would echo what Suzanne's saying. It's about, are you doing the tool to do the tool, or are you doing the tool to know what to do for a plan of care? And so, and I don't know what the answer to that is in your situation, but it might be something just to reflect on and think, are we doing it when we know the answer? Because I think we do get into a terrible habit of ticking a box to prove we've done it when actually we knew the answer. My issue really is we do the tool at a change in circumstance or at a set review date, because what we're trying to do is act on the outcome. And if all you're doing is ticking the tool and telling you what you already know, is the tool the value that you need, I suppose, would be my challenge. Not really doing what you need it to do. So sometimes you need to be brave and say, actually, we're going to implement the tool unless there's a change in condition. Then we won't revisit it until. And sometimes in ITU, it's quite normal to do something at 72 hours, or whereas in our inpatient units we do it at a week, unless there is a change in condition. So we sort of set some boundaries in our inpatient units around that, and it might be you need to do that, but just shorten the time frame, but maybe not every day.
Yeah,
I think
it's
as well,
nice guidance as well.
But weekly wouldn't probably necessarily sit with your cohort.
I think what's really important is the ongoing skin assessment. So you're evaluating the care and you can see where there's deterioration, which would then, might prompt you to reassess.
Okay, well, I'm going to draw it to a close there because we've slightly slipped over our time for questions and answers. But thank you so much for engaging in that. And I'm really, it's triggered more thoughts for me, and I'm sure it has for all of you. Our next point on the agenda.